We've all seen the articles. Michael Levitt from Stanford University gave an interview with the Los Angeles Times, and we've all seen the resulting articles that say he is predicting that this pandemic will be over faster than we think. He's predicting that based upon what he sees in the data, the curves, the rate of increase is rolling over and it will soon begin to decline in the United States. Levitt, like a number of other people, can make predictions that position themselves to be the hero if they are correct. And we won't know if they're correct for another 3 weeks, another 3 months, however long it is. If they are correct, then we get to look back at their prediction and say, aha, I'm the genius. I was right. If they are incorrect, they will be relegated to the forgettable dustbins of history. There will be no consequences for having been wrong. And so when Levitt makes a prediction, he positions himself for a reputational upside with very little reputational downside. The question is, do we act upon a prediction or do we act upon a possibility? It may be that Levitt is right and that we begin to see these curves turn over. I saw an article about New York and the headline said that cases jumped 20% overnight in New York. But the previous day, what the headline didn't mention was they had jumped 37%. That could indicate, if it indicates anything, that the rate of increase is declining. And this is Levitt's point. Levitt could be right. Does it mean we should do anything differently? Does it matter if Levitt is right or wrong? And the answer is maybe not. What we don't need, this is Seeger talking, my thesis, what we do not need are such predictions, because predictions have a way of creating this cognitive, this confirmation bias in the decisions that we make and closing us off to alternative possibilities. So there's a couple of things I want to talk about. When do we know that the trend is changing? And what do we do about it when we know it?
So first off, I think that the statements like the one you're referring to are remarkably superficial, and we have a plethora of superficialities. It makes one point that we made at the beginning of our discussions, that rate matters. Second is the two rates matter. Again, it leaves out the second rate, which is related to the experience of harm from the virus and harm that we can affect. The second rate—
There are two rates. The rate at which demands on the healthcare system is increasing, and the rate at which we can build new capacity in the healthcare system. Those are the only two that matter. Total cases is now irrelevant because we're past the stage of the pandemic where we could test, track, and isolate.
Right. So what we're seeing in Italy and New York are what happens when they get slammed. What we're seeing in Germany is a place where the expansion of capability in interacting with methods that reduce the transmission rate, so the rate at which people need hospitalization and ICU level care, are such that there's good care for the people who need it. And so if the case numbers are higher, hospitalizations are still significant, but they have the capability to meet those patient needs. Fatalities are relatively low. Now, the first mistake, and we've seen this in many things, is that the virus, if left unchecked, the do nothing number, the do nothing baseline, is the transmission rate will turn around on its own because the virus will run out of hosts to infect.
It may run out of hosts to infect because it killed everybody. That's one way of running out of hosts to infect. We know that this virus will not kill everybody. But one of two things will happen. Either the patient will recover and develop antibodies and have some unknown duration of immunity, or they die. Does that sound accurate?
Well, I mean, we have this mix in this case, which makes this virus most disruptive. Ebola killed too many people too quickly to be a good virus.
Yep.
This virus manages to spread itself maximally, right? Because it's of its transmission, and the fact that people can transmit without knowing that they've been infected. But the issue is the baseline number is it'll turn around on its own when 60, who knows what percent of the total population in a particular vicinity have now been exposed to the virus. The issue is our action potential to make a difference, which is, can we reduce the transmission rate sooner than that baseline number, the do nothing number? And that's what's happened in some of the Asian countries that have broken the transmission. Germany right now looks like it may be in that position. And so we know we can do better than the do nothing number. And so what we're looking for is what's the most effective way to not slam the hospital system. If we slam the hospital system, we have excess deaths. In other words, more deaths than the best places can pull off. Now, we don't know exactly what that baseline number is, but we know it's below 1%, perhaps well below 1%. And we know something about what that number can be if you, again, it's not 1%. We don't have the right statistic on our percentages, but we have
But
something.
It's higher if we don't have the medical care necessary for the people who need it.
Right. And
fatalities increase.
And my current estimate is that, and so that's our excess death number. And what we also have action potential to reduce our excess death number. And that's a ratio, right? From what's the best anybody's able to do in terms of minimizing mortality relative to if we handle it poorly, what's the kind of mortality we are likely to end up with. The evidence we have points to a factor of 4, 7, 10. Right now, right, Wuhan adjusted statistics indicate that places that did better than Wuhan, right, Wuhan was 4 times the number of fatalities, maybe a little less. Spain is running 7 times, right? Italy's running well over 10 times. So I've said before, 10 times is a number. Maybe that needs to be closer to 7 using Spain current status. But the point is there is a significant multiplier in unnecessary mortality if we handle this outbreak poorly in this rolling outbreak in the different places where it starts to grow. Now we don't
Allow me to recap a few things that will look familiar but are a little bit different. What I've done in this cartoon is illustrate the difference between exponential growth here and logistic growth here. Exponential and logistic growth look the same at the beginning of the growth curve. They're very similar. Even though the equations are different, the data looks the same. Nothing grows exponential forever. Everything must be logistic because at some point, everyone in the world who can be infected will be infected. The rate of change in these curves is in the green dashed line. Those are the new cases. It increases to the point at which this slope is a maximum, and then it goes back down. So the green dashed line is the rate of change in the logistic curve, or new cases. There is now a discussion about where is the United States and different regions of the United States on this green curve, because the green curve will control the change in the black curve. It may be that New York City is at the apex. It may be that New York City is down at this pseudo-exponential increase stage. Louisiana might be the same. We don't know because there's so much noise in the data that it takes several days, maybe several weeks, to determine the true shape of these trends. Does that sound right?
I want to ask Dave something that follows up your point here. The thing I find missing, given that we've emphasized it's about rates, is the time constant of the processes. We're trying to understand the rates. And the rates matter because we're trying to match rates, rate of expansion of healthcare to match the number of serious cases. We're also interested in when the transmission starts to decline, so we're going to have less cases, less hospitalizations. So we can start to see where this may, how this thing can start to move into a post-outbreak monitoring and preventing flare-ups. So Dave, where and how do we get data on the time constants?
I don't think I'm going to have a satisfying answer to you, because it's even worse than everything that you said, in part because of all of these. I mean, and maybe we're using the same terms. You're using time constants. You've also used the term, these are lagging indicators, right? So we have these delays that, as you have pointed out, are on several different scales, right? Or at several different parts of the process, right? The time from which one is exposed to the virus to the time at which one actually starts to present symptoms, right? The time lag at which they then maybe self-report to the hospital, right? To the time, and we know that the data that is being collected and aggregated is also maybe not being aggregated in a way that makes the most sense, right? So in a previous conversation, we talked about that, at least here in the United States, a lot of the reporting is happening at the state level, when in fact, perhaps what we ought to be doing is reporting things at the metropolitan level, to the extent that you have large populations that are interacting, right? So the jurisdictional boundaries that are being used for reporting, which also are often the same jurisdictional boundaries by which governance happens, right? By which you have city mayors or state governors putting policy decisions in place. These things don't necessarily align. And so the data capture problem is real and is significant. And so, I don't know that we have good models for trying to interpret in a real-time sort of way these noisy indicators and trying to make good estimates based on them. I'm quite confident that in retrospect, we will go back and fit models to kind of say what really did happen and what really did happen at the appropriate geographic and population scales to understand this. But I don't know that we have at least the things in place right now to understand these stochastic processes in a way to be able to provide good estimates of what's going on.
Right now, we have we'd like to believe we have good data on deaths, but we don't necessarily. And that's because each physician has discretion about how they report the death. And then those deaths must be aggregated, typically, as you said, at the state level. And there can be distortions in reporting practices and delays in the aggregation and reporting to scientists and policymakers. But even if that were perfect, deaths would be a lagging indicator. We have reports on case test data on how many cases there are. But there, it is also, as we've discovered, a lagging indicator. The fact that there's all of the lag in the reporting system means that we're trying to race through this fog by navigating through the rear view mirror of the ship. We can only see behind us at this point, and yet we are traveling forward in time. Hospitalization data is more of a current state. I'll help us forecast deaths. We've only been getting hospitalization data the last 4 or 5 days, as far as I can tell. The point being that there are lots of curves, and these curves are displaced on this axis of time. I drew this a few days ago, and I didn't show it. There is a time lag between the rate of infection and the rate of fatality.
So I think we just beautifully illustrated that how we're getting these very superficial claims. And because there's a nugget in them, one, rate matters, turnaround matters. It seems sensible and insightful, when in fact, all the rest that follows is at best misleading because of what they don't get into, what they don't relate to. But independent of those things, when we start honing in on the critical stuff, we have to remember we're in the middle of it. As Dave just said, we'll figure it all out over time when it's over. and we'll have great precision in what we'll be able to say and interesting arguments over that, interpretations. But now somebody has to make a decision to act, and to decide not to take actions is a decision, or to stall on making a decision is making a commitment. So what do you commit to? And that relates us back to, how do we use uncertain information in an uncertain world with noisy information? What do we rely on to do things?
I think there are 2 points here. One is the problem that we have with testing, right? So we've talked about the failure in testing prevents us from exercising a strategy that has to do with test, trace, isolate, which is well known among experts to be the most effective, both from a public health outcome as well as from a cost perspective in terms of being able to deal with these. Our inability to test really hampers us, but it's this inability to test that also leads to this inability to measure more broadly, right? Which means that we're stuck with only these lagging indicators, with only the ability to be watching in the rear view mirror as we're racing forward, right? So to the extent that there are some lessons to be learned for future incidents, and or whether or not there are some opportunities for us to maybe make some changes in real time while we're flying the airplane or racing the car, whatever it is, there may still be things that we can do about using testing in a smart way that helps us navigate. So that's the first point. The second point has to with decision-making in this presence of uncertainty. And at the risk of mixing too many metaphors, I want to talk just a little bit about a game theoretic perspective versus a probabilistic perspective. So this is a debate that was quite prevalent in the early days after 9/11, when there was newfound concern about terrorism risk. And the question very much was about, how should you treat terrorism? Should you treat it in a probabilistic way like the weather, right? Or should you be using more of a game theoretic framework that is based on the decision-making of an intelligent adversary? And so the analogy that I want to draw, so just to be clear, what we're talking about here is that in some cases, you may choose to make a decision based on what you think will happen. You have some best estimate or some guess as to what's going to happen, and you are going to commit resources, you are going to take action in anticipation of that. And there are some instances where that is the right thing to do. When you have really strong information over short time scales, you can act with confidence in this way. When you face broader uncertainties, or in particular, when you face an intelligent adversary, right? The traditionally military decision-making in particular does not gamble based on what you think your adversary's most likely course of action will be. You do it based on what could happen. You tend to be much more conservative in this, right? And I'm not suggesting that the coronavirus is an intelligent adversary, right? But what I am suggesting is that this, in the presence of this uncertainty, there's this tension between, do we have a sense of what we think is going to happen? Are the numbers turning? Are things leveling out? Is it safe to go outside? Or are we going to be conservative, and are we going to be worried about what could happen? What could happen is this surge that we're waiting to come in the presence of these lagging indicators that are going to continue to overwhelm these kinds of things, right?
Anticipation is this imaginative exercise. These are all the possibilities. One possibility is that Louisiana is in the throes of an impending epidemic that will devastate the elderly population in New Orleans. Another possibility is that the days get longer, the temperatures change, people get more sunshine, and Louisiana has already seen the peak in their infection rates. How do we prepare for two wildly different possible futures? Now that we've imagined them, we need to act, allocate the resources, make commitments in an adaptive way as that future comes rushing at us.
So there's two things about that, right? From when we study people responding to a variety of kinds of challenge, crisis, anomalous events that risk major disaster. And the thing here is that we see people anticipate bottlenecks ahead and prepare to be able to generate the capability to act should that bottleneck start to happen, even though the probability of being in that bottleneck may still be statistically low. And that is that if I don't generate the response capability in advance, slightly in advance, I can't generate it very well when I'm in the middle of the crunch. You see that being played out in New York as the trying to add more capability, stand up new hospitals as a surge threatens to overwhelm.
The governor of New York gave a press conference. He said he needed 30,000 ventilators, and the feds had sent him 500. At that time, there were only 3,200 people hospitalized in the entire state of New York. I don't know how Andrew Cuomo calculates that he needs 30,000 ventilators for 3,000 people in the hospital.
We're back to superficialities.
Correct.
Let's focus on the action. And the action is build response capability. And how fast can you reinforce your existing response capability as overload threatens? So I come up with an answer. So we have two answers. One, historically in studying these responses, is support people generating the response capability. You will over prepare. In other words, the surge may not be as big. It may turn around sooner. And the time delays in producing those reinforcements, those resupplies, that excess capability matters a lot. We can add those to your diagram, right? And so waiting to generate more protective gear, waiting to generate, to ramp up capability, right, delays when it could go into action. Also, we get some people going mystified like, hey, I could make new ventilators, but I can't make them in less than, 30 days, 60 days, 45 days, right? Again,
right. They could be long lead time items in which we would lose our adaptive capacity if we do not act in anticipation of some scenario that may never come to pass.
And in these things, we come back, and we've documented this very clearly in the resilience engineering work from the get-go. And in fact, it was one of the things that helped start it, was afterwards, when we look at these things, we'll say we over-prepared, we over-generated capability, we didn't need it all. That some of the time we'll know we needed it, but a lot of the time we won't know we needed it, right? Italy knows we needed it. Well, will Texas need it or Arizona need it? We don't know now. And maybe not, and probably there'll be some places that generate capability they don't need. And so it looks wasteful. It looks overkill. It looks like we didn't need to do it. And that
we'll eventually use the masks. We will eventually use up the suits. The ventilators can stay somewhere in a strategic reserve if we never need them. They don't expire or go bad. It's okay. Perhaps they'll be ready for a second deadly wave. Perhaps we can ship them to another country, to Australia, as they enter their flu season, because their summer is over. These things, the personal protective equipment and the kinds of capital investment required to respond, these things will not go to waste. What will go to waste?
Well, I understand where you're going, but let me finish what we came up with. What we came up with as a way to deal with your previous question and direction. And that is, you measure, right, what you're interested in is how fast is the capability to respond saturating. If it's saturating quickly, if you're starting to risk saturation, could be because you're running out of response capability, you didn't recharge it fast enough, or it could be because demands are speeding up and outpacing your ability to tackle those demands. But what we keep observing in different scales of biological systems and human systems that are successful in this, they're very sensitive to, I am starting to get overloaded. And I'll give you a place where I look at ICUs that aren't slammed. And I ask contacts or people who have contacts with those places and say, what are you seeing? And we see them ramping up capability, and we also see them starting to feel stress beyond the normal. Mm-hmm. They're undergoing stress right now in places that don't have the numbers on the aggregate charts. And so that gives me a sensitivity to where things are going and the importance of acting in advance to generate capability, identify potential shortfalls, resupply or buttress those capabilities. That's where you get benefits. And that's what we have biological, cognitive, and larger scale human system success stories. And they all have at the heart that ability to read that increasing risk of saturation, generating new capacity to act in advance of the crunch. And so that's what we focus on. That's what the theory lays out. That's the kinds of action items that can go. And we can show that these things can tell us what to invest in, where it's not just efficiency that we are optimizing. It's not just adding a little robustness on a few well-known failure cases and failure risks to our optimal approach. Right? That's what this is really revealing, is the whole hospital system has been too optimized in a particular direction without the capability to mobilize and generate new things. And the inability to generate tests, the inability to generate protective gear are societal indictments, not just medical system indictments, that we're not ready for large-scale challenge events.
It seems as though there's another type of response and another rate that's important here, which is our capability and our rate at which we can test in this context, right? So it's not just about generating the capacity to respond. Obviously, that is fundamental to actually dealing with, getting overwhelmed, right? The deluge of patients that come in and whatnot. But the ability to increase your sensing helps you to figure out where you're really going to need these, where do you need the most adaptive capacity, and where can you compensate? Where can you work together, right? Where really are you going to need the ventilators, right? Where can you share resources, right, in a networked kind of way? And one of the things that, while there has been some focus and discussion on creating more tests at different laboratories and whatnot, it seems to me that one of the other things that we haven't maybe given as much attention to is how do we increase this capacity to test in a manner that gives us more advanced information so that we can respond in a more appropriate way. I just want to draw that connection.
That's a brilliant addition to the points we're making, that we aren't targeting the testing in a way to maximize our information. That's really excellent. Again, on Tom's point of where do we put and your point of where we put information in order to know what kind of actions to place value on. And one of the things I want to mention is the healthcare system is undergoing 3 forms of stress right now. Right? It's not simply the number of patients in the ICU with COVID. Right? First off, all these systems operate at near capacity. I've used the example of emergency rooms that sometimes act above their nominal capacity for handling patients on a regular basis. So all of our systems are poised in terms of caseload, economics, a variety of factors. As one physician said, we're already busy with our standard non-COVID-19 patients. they still have to take care of their non-COVID patients and the stream of new patients who come in with different kinds of conditions. So they have to maintain care, even if they can relax and deprioritize some aspects or transfer it to telehealth. They still have to do that. They have to ramp up for handling COVID patients, and they all understand from the beginning that this is a new disease. It requires them to reconfigure their normal techniques, their surveillance, their sensitivities, their risk management protocols, everything at the level of respiratory therapy and ICU care, critical care. They have to reevaluate. And they're very open and sensitive to the need to revise and continue to revise as evidence. They're hungry for information. How is this going to play? At the same time, they recognize any of these lead information are very tentative and need to be recognized when something new is coming along that says, oh, it's not quite that, it needs to be this. And we see this with the example of the emerging cardiac risk, that patients who are starting to recover and look on the road to discharge have a sudden cardiac event and that turns fatal. So this is new information, and they start looking at ways to deal with this. And then the third thing is they have never worked at this scale before. When they think about extending their capacity, as you know, it's like, well, if every doc worked 24/7 who's a specialist in these conditions, we would barely have enough to cover the ventilators, the number of ventilators we have. So it's just not the number of ventilators that matter. It's the expertise to use those ventilators. It's the staff that's needed to monitor those patients on those ventilators. Can we scale them up? Well, we can, but only if we completely reconfigure the way we work. The fact we need to be sensitive to new information and be ready to revise some of the ways we do things as that information comes in means we have to revise the way we gather information, interact with each other, and communicate. We see these hospitals completely reconfiguring the way they work, and it's not just at one level, the ICU, it's at all the levels of the hospital. So we have a third burden. They're interacting in new ways through new kinds of tools in order to keep pace with what's going on and to work at the scale that a surge could conceivably demand of them. So those are three different ways that a hospital system is under unprecedented kind of stress. Now, what can we do to support them get through this stress? There's an difference between when will the stress end so we don't have to worry about it versus can we push support to help them?
Essential distinction. The predictions are irrelevant. The support is relevant.
That's right. And in the end, again, we'll over-support in some ways, or we'll be ready for something we didn't have to deal with. This will be the drill, right? Because I've had people talk about, did they do a mass disaster drill or that had an infectious disease component versus a 100-person shooting or something, or a large-scale industrial event, right? Did they do it with infectious diseases? And what do you get? Well, we kind of walked through one at one place I was at. Well, we've never done it at the others. Or we focused on these other things when we did drills, not this one. Well, the places that don't get slammed, thank God, and hopefully there'll be many of them, getting prepared is still necessary. And these now become the most realistic drills that prepare them not just for this outbreak, but for other kinds of large-scale disasters. And we should be mining and sharing the results of these kinds of super realistic running up capabilities, thinking through how would we work at this new scale if we got slammed.
I want to close with a question. The question, and I'll start with my own answer. The question is, when is COVID over? And in our current environment of suppression and quarantine and isolation and social distancing, the answer is it's never over. You must always remain vigilant for flare-ups. And I'll grant that. I'll put that aside for a second. However, the measures of shelter in place, the orders that many states are under that have shut down sectors of the economy, it's what we're really asking is, when is that part of COVID over? And based upon the conversations that we've had in the last week that say the essential rates are the rate of people who need intensive care or hospitalization and the rate of the healthcare system at which they can provide it. These are the essential rates. COVID is over when we have the infrastructure in place to implement test, track, isolate. It is the best and most cost-effective way of responding. COVID is over when we have built the capacity in the healthcare system to accept the rate of patients who need it, or COVID is over when we have immunity in the population and the virus has run out of people who are at risk to infect.
I think you covered it all, except you left out some before that last one, which is that it's over when we have treatment and preventative measures to deal with the spread. Another one is it may be over in the natural mutation, the interaction of our treatment and prevention mechanisms with the natural mutation rate of the virus, which we don't know what direction and how that will go. But regression, given this one's so perfectly poised, regression to the mean says mutations are likely to make it less difficult to manage over the longer run.
Although there is no guarantee, given how pervasive it is in the asymptomatic population, there's a lot of natural experiments running, and it's possible that one human-to-human contagious mutation, this one would make it more lethal in a way that people with existing exposure and existing antibodies might still be impacted. There are lots of possibilities, and they all lead to the same kinds of commitments. Implement the infrastructure that we need for test, track, isolate. Improve our capacity to deal with cases that need care. And I like your addition, there are develop new treatments, both preventative and responsive, that will reduce the intensity of the care that people need.
And remember, we've also said that the transition on the economic activities and normal activities is partly, as being relaxed in Wuhan, is when you break the transmission, when the hospital system has accommodated the number of sick people, then you're in a position to go into a monitor for flare-ups. And that's a reasonable stage to be in, where you can relax restrictions on interactions. And you're exactly right. The faster you can relax those restrictions is correlated heavily with your ability to do testing, widespread testing. So you need a surveillance mechanism. So moving from a post-outbreak to more normal and a relaxation to move to more normal depends on that surveillance mechanism. So I think, and Dave, jump in, but I think you've laid it out very well. This is where the action is. And this is what discriminates among the actions. And these, again, have different time courses for when they're going to play out and different risks as we develop some of these things.
One of the things that we've discussed previously is it's not being at a particular tempo or having a particular capacity that makes you prepared. It's having the ability to change those tempos as needed. Right. So COVID's not over when there is, so one future you could imagine is that we now have thermal scanning at every storefront or restaurant. Right. So we live in a world
screen
where
people for fevers or whatever it is. Yeah.
Right.
Or maybe we're going to double ICU capacity in every major metropolitan area. And now, that's not your point.
So the
Those
point
are state variables.
It's not about the having, right? It's about the doing, and it's about being able to change and respond, right? So even when, as David points out, even when this particular virus or strain of virus is over, right? We still face the possibility of new variants, some of which could be even worse, right? So while I agree with David that, this one is so well poised that in sort of the grand scheme, we would expect mutations to maybe be less well adapted to proliferate. At the same point, there are a lot of experiments running that are tweaking a pretty good solution, right? So we might find an even better one, better from the virus's perspective, right? Bad news for us. right? So we need to be prepared in that way. And it's not, again, it's not about the having, it's about the doing, right? And that's the point at which I think that, we might say that COVID is over when we have this ability to scale up to meet the tempo of some kind of outbreak. And it seems to me that, again, connecting to what we were talking about previously, it's not just about having thousands of ventilators at the ready. It may be about the ability to very quickly push out testing in a very localized but broad way. What would it mean to be able to test all the inhabitants of a town or
Sure.
A county or something like that?
What would it mean to test at all the public schools? Yeah, and private schools, right?
Right.
Yep.